Good morning, little elves. Here we are. It's Sunday. We've got a wonderful podcast. I'm joined by my two colleagues, Dr. Sam Jejurikar. His Instagram handle is at Sam Jejurikar. He's in Dallas, Texas, of course. And Dr. Sam Rhee, his Instagram handle is at Bergen Cosmetic, and he's in Paramus, New Jersey. I'm, of course, Santa, also known as Dr. Sal Pacella, at San Diego Plastic Surgeon. And we've got a special treat for you this evening, or this morning, excuse me. But first, before we get into that, I'd like to do our disclaimer. This show is not a substitute for professional medical advice, diagnosis, or treatment. This show is for informational purposes only. Treatment and results may vary based on the circumstances, situation, and medical judgment. After appropriate discussion, always seek the advice of your surgeon or other qualified healthcare professional with any questions you may have regarding medical care. Never disregard professional advice or delay seeking advice because of something in this show. Now, this morning, you can either be on the naughty list or the nice list, and I'm going to send it over to Mr. Naughty right over here, Dr. Sam Jejurikar.
Okay, well, on that note, you'll notice that although we are listed as three plastic surgeons, there is a fourth face staring at us, and it's my great pleasure to introduce Dr. Michael Orsek. Dr. Orsek's credentials are impressive. He is a former president of the South Carolina Society of Plastic Surgeons. He's actually on the Board of Trustees for a large healthcare system in South Carolina, the Spartanburg Regional Healthcare System. But the reason why he's here today is not because of his credentials, but mainly because of his expertise in microsurgical breast reconstruction. So a little bit about Dr. Orsek. I've actually known him for 15 years. I had the great pleasure in training with him at Manhattan Eye, Ear, and Throat Hospital in aesthetic surgery, where he is a top-notch aesthetic surgeon. But after he finished his aesthetic surgical training, he decided he wanted even more for his practice. So he did additional training in microsurgical breast reconstruction in Gent, Belgium, where he really focused on perforator flap reconstruction using DIEP flaps or DIEP flaps, which is going to be the focus of today's show. So Dr. Orsek has a booming practice in which he focuses on aesthetic surgery of the face, body, and breast, but he also does a huge number of microsurgical breast reconstructions. And he really is considered to be a regional and national expert on this, and it's our great pleasure to have him on there. So, Mike, thank you for joining us.
Well, thank you for having me. I've been excited all week.
So, as have we been. You really class up the joint, particularly with drunk. Compared when you're juxtaposed next to drunk Santa over there. So, Mike, tell us a little bit about how your passion for microsurgical breast reconstruction came about. Why did you decide that you wanted to do this very specialized aspect of plastic surgery?
Well, that's a great question. When I decided to come back to South Carolina following training in New York City, I quickly realized that there was a great need for top-notch breast reconstruction. At that point, the patients were either great implant candidates or they didn't get breast reconstruction. They were told they couldn't have breast reconstruction if they were overweight, a medical issue, or especially radiation. So with that information, there was so many patients that weren't getting properly treated. So being the new guy in town, these patients started knocking on my door, and just one after the other, and decided that it was time to really turn up the training that I had, the excellent training that I learned from one of my mentors, Dr. Ritter, who taught me microsurgery, to really offer this to patients. And as you had mentioned, with all this new influx of patients, I quickly realized that there were other microsurgical options that needed to be offered to my patients. So I left my practice really quick and went to Belgium for a few months and really fine-tuned some other operations, not only the DIEP, but PAP flaps, CAP flaps, so on and so forth, and came back. And my practice just took off from there. So
you had mentioned that you felt like there were patients that weren't getting appropriate treatment. And I'm sure you still do some implant-based form of reconstruction. How do you determine who's a great candidate for a microsurgical breast case? Well,
I think the easiest patient or decision to make would be a patient who's had mastectomy in the past and radiation. Though there are some doctors that will try to expand that, in my mind, I think in most plastic surgeons' mind, it's a pretty bad idea. So bringing in new non-radiated healthy tissue makes a lot of sense. Okay,
and in the hands of plastic surgeons that don't do a lot of these procedures, for instance, myself, this is an incredibly time-consuming, laborious process to do these sorts of cases. When you do a typical bilateral reconstructive case using microsurgical techniques, let's say a DIEP flap, how long does it take you to do that operation now, and how long did it take you when you first started going?
Well, when I first started, I wouldn't undertake bilaterals, and I remember unilaterals would take 10 to 12 hours. But today's Sunday, and Friday, I did bilateral DIEP flaps with nipple-sparing mastectomies, and we were done in 7 hours.
Wow, that's really good.
That's great.
And typically, how long do your patients tend to stay in the hospital when you do a case?
A unilateral 2 days and a bilateral 3 days. And now that we do a lot of out-of-town patients, sometimes they'll stay a full 5 days before we let them go back to their other states.
So please go.
Sorry, yeah. And Mike, do you tell us a little bit about the OR setup that you have there? You work with obviously a mastectomy surgeon, but what does your team consist of?
So my team consists of, I have a PA. She's been with me for a couple of years. She came from Knoxville, Tennessee, very talented. So she will prepare the chest, dissect out the internal mammaries while I dissect out the flaps. Now I have a scrub tech who's incredibly talented as well, Desiree, and she helps me dissect out the flaps. Then I also have 1 or 2 associates who will pop in if they're available between cases, and maybe I'll dissect out a flap. If the chest is ready, I'll pass it up to the chest, and they'll do the micro while I while I dissect out another flap. So there's always operating going on, whether it's the chest or the abdomen. We really try not to waste a lot of time.
Do you wait for both mastectomies to be done before you start working, or are you able to prepare the abdomen while the general surgeon is doing, or the breast surgeon is doing their work up top?
Yes. I always work at the same time. That shaves off a lot of time for the patient. As a matter of fact, many times, one of my assistants is dissecting out one of the chests after the mastectomy has been performed while the oncology surgeon is doing the mastectomy on the other side. That gets a little crowded, but it works fairly well in certain patients.
That's great.
So, Mike, you've been nice enough to actually put together a couple of cases to help illustrate sort of what's achievable with these sorts of operations. Would you mind sharing them with us?
Certainly. So the first case I wanted to discuss was a young woman who underwent bilateral mastectomy with immediate reconstruction with DIEP flaps. And this slide will show her pre-op photos, her intermediate photos after the first stage and the second stage. So you can see a lady with the BMI around 38 with significant asymmetry, ptosis. So through a skin-sparing mastectomy, we performed her reconstruction. Now, if you look at the intermediate stage after the DIEP flaps, you can see she has some significant asymmetry, some boxiness of the breast, just overall an okay result, but certainly needs some fine tuning. And in the final picture, we could see she has a nice symmetric result, nicely rounded out. And the reason why I wanted to show this to you was I think we sort of get hung up on trying to do these operations through tiny little incisions, the smallest scars possible. But as you all know, as great aesthetic surgeons, if a woman that presented, such as this lady, wanted aesthetic refinement of the breast, I don't think any of us would choose anything but a wise pattern type operation. Mm-hmm. So for an aesthetic patient to put those type of scars on someone's breast, we shouldn't hesitate at all to do that on a reconstructive patient. And I think once we liberate ourselves and realize we need to get the nicest shape possible, and scars we can manage, I think we can wind up with results like this.
And just for our viewers out there, I mean, let's just take a step back for the non-plastic surgeons watching here. So correct me if I'm wrong, Mike. This first photo on the left, that's prior to any mastectomy, correct?
That's right.
Okay. And then she had this 8-hour operation where both breasts were removed through an incision around the nipple, correct?
Right.
All right. And then you went in and you took 2 big, large pieces of fat from the abdomen and hooked up to the chest wall with blood vessels to the chest wall to make what's the bottom photo, right?
Right.
Right.
And then after that, a few months later, you did a nipple reconstruction to make this absolutely perfect. So the gravity of this here for everyone out there is, this just looks like a little operation here. This is a massive operation where both breasts are removed for reconstructive or for cancer reasons, and an unbelievably hardy reconstruction is performed, which basically you can't tell. I mean, that is just phenomenal. Absolute fantastic work.
Was this patient radiated too, Mike, or no?
No, this patient was not radiated.
But for our viewers, just to belabor what Dr. Pacella said, this looks like a woman who underwent a tummy tuck and a breast reduction and got a great result from a non-cancer operation. This is a lady who had cancer, who had her breast entirely rebuilt. Dr. Orseck and his team hooked together blood vessels under a microscope underneath a rib in the chest wall to create these what appear to be healthy appearing breasts, and then got like an absolute, this is the best result I've actually ever seen in an obese patient. And then you didn't point it out, but you look at her abdominal wall and how much smaller it is. It looks as though she had a tummy tuck and a breast reduction. So Dr. Orseck is very modest and understated as always, but this is an exceptional result.
Thank you.
You know, what is amazing to me is hearing you talk about doing a WISE pattern, and it never occurred to me, why didn't we ever do these on oncologic patients? We do them all the time, like you said, aesthetically for regular healthy patients. Is this a concept you came up with yourself, or did you?
I'll tell you why we don't do it. These keep in mind, gents, like, not everyone, there's a big difference in mastectomy surgeons across the country. Some leave tiny, tiny little flaps. Others leave hardy, thick flaps. Some of it is patient dependent based on what's left behind. So, a main reason why I think we have all steered away from WISE pattern incisions is because the tip of the incision right here, that T junction, if you have an exceptionally thin flap, that's a flap that we're always worried about dying. I mean, I have huge challenges in my practice with this. So, Mike, sorry, I interrupted. Go ahead.
Yeah, sure. So I think the incorporation of skin sparing, nipple sparing mastectomies are great in the right patient. But certainly this patient, we could have done nipple sparing and given her back the same appearance of her breast, actually worse, because the flap would have fallen down right behind the nipple. She would have had no upper pole fullness. Sure, we could have done it scarless. The scar would have been in her crease underneath her breast, but I would guess that most women would like this final result rather than to look exactly how she did pre-op, with some scarring. She has some scarring, but overall, I think it's much better.
I mean, because I think when I see a lot of microsurgical breast reconstruction, the intermediate result is more sort of the normal average result that I've sort of seen. So when did you start saying, listen, I need to do better shaping. I need to make this more aesthetic. The incisions are not so much of an issue as the final breast shape.
Right. So that is all part of my journey through breast reconstruction. For the first couple of years, it was staying up almost 36 hours straight, just hoping that the flap survived. Right. And then once you get your flap survival rate to where it needs to be, and then you worry about, well, how do I get these flaps, even though it survived, to minimize or eliminate fat necrosis? Because as we know, fat necrosis is about the worst thing that we can get. And for the patients, fat necrosis is an area of the flap that doesn't get good blood supply, and it turns into a firm nodule. It actually feels like cancer, and it doesn't heal well, and it drains, and it's very hard to manage in the second stage. So getting the flaps to survive, avoiding fat necrosis, and then shaping, really getting the best aesthetic results I can get, came later. And going to a lot of meetings and learning from some great aesthetic surgeons, such as actually the one that you had on last week, Amy, learned a lot from her about shaping the breast. But so taking the aesthetic lessons that I had at Manhattan Eye and Ear and listening to a lot of reconstructive surgeons and a lot of aesthetic surgeons, you just realized there's so much more that we could be doing to shaping the reconstructed breast than just kind of throwing a slab of tissue up there and calling it a breast.
Mike, you make a tremendous point here, which is, I think so many times we get pigeonholed into our specialty. Oh, you're only an aesthetic surgeon. You're on the Instagram. You're not doing anything challenging. The reconstructive surgeons say, hey, those people that do cosmetic surgery, they're kind of in another class. We're kind of dealing with humanity here. We're curing people from cancer, but we are all one specialty, and there are lessons that can be learned easily from reconstructive surgery that are applied to aesthetics and aesthetics to reconstruction. And I think you've hit the nail on the head here, and that's a major reason why I've been so happy to be involved with skin cancer reconstruction of the face. I take a lot of what I learned in the cosmetic facial world and apply it to reconstructive surgery. And you have done exactly that with this type of case. And it just hints at your training. It hits at your dedication. So that's just phenomenal.
Absolutely.
Thank you.
Absolutely.
Santa's putting you on the nice list.
I see.
Okay.
I'm very excited about that. Thank you. I wasn't expecting to be on the nice list this year, but no, that's great. I'll take it.
Well, maybe you get a visit from Hanukkah Harry too. Okay.
Right, exactly. I really should have brought my Hanukkah glasses today.
Did you say you had a second case too, Mike?
I do. So this is just the before and after of the previous case. Okay, moving on. Second patient, another young woman who had a genetic predisposition to cancer as well as currently having cancer. She too underwent immediate flap reconstruction at the time of her mastectomies. And this young woman also had the wise pattern shaping. And I just wanted, again, to highlight my lack of reluctance to put extra scars on a breast to get the results I'm looking for. So again, a woman with asymmetry, significant ptosis, cut out a lot of her skin at the time of mastectomy, and put in a little skin paddle. That's actually her abdominal skin, that little oval of tissue at the bottom of each breast. Now, certainly, someone could have said, hey, well, let's just fat graft the upper poles and try to give volume. But, those aren't really shaped like breasts. And if you look at the final picture, adding some additional scarring and hiding those scars the best you can, coupled with some fat grafting, really gives a beautiful shape. And same principles as before, using aesthetic surgery principles that we do every day in our practice. Breast reductions, breast lifts, with or without implants is the same pattern. And you can get reconstructive results just like this. And Samir, as you said before, that was the best result you'd ever seen in your life. I'm very humbled by that, but it's something that's been invented for the last 75 years, I would imagine. But just incorporating it into reconstructive surgery, I think is fairly new, and this is what we can do.
Standing on the shoulders of giants, right?
Exactly right. I didn't invent any of this. I just borrowed a little bit here and there.
Well, now, Mike, can I ask you, tell us a little bit about the timing in between these first and second stages. What do you do? How do you factor in the patient's chemotherapy? When are you doing the next phase?
Sure. So today, many patients are receiving chemotherapy before their mastectomy. That's called neoadjuvant chemotherapy. In that patient, I like to wait 6 to 8 weeks until they get their mastectomies and to do immediate reconstruction. If someone is planning to definitely have post-operative radiation, I will also do the immediate reconstruction, leaving the side to be radiated a little bit larger to anticipate some shrinkage after radiation. So we tend to not shy away from post-operative radiation like I would if someone was going to have implant-based. And I think that cuts down on the number of operations, and the patient still winds up with a very good result. As a matter of fact, the scarring on the radiated side is often better than the non-radiated side.
I have a couple questions real quick. One is, what is your percentage of implant-based reconstructions versus autologous reconstructions, would you say?
I do 80% autologous reconstruction. I have some very good surgeons in town who, if the patient really expresses a strong desire for implant-based reconstruction, they will also go to those doctors before they see me. But I still do a fair amount. There's, as we know, just some perfect candidates. A B-cup breast who already has implants that did very well with their implants, who's not planning on radiation. It's great just to use a pre-existing capsule to switch out for some larger implants.
And then for your autologous, what are your breakdowns in terms of DIEPs versus, say, like a pedicled latissimus or any other type of autologous?
So a pedicled latissimus, I'd say, is about 1 out of every 10 or 15. I use that in my morbidly obese patients or someone who has an abdomen that's not usable, or also if their inner thigh isn't usable.
And then what was the learning curve like? What was the hardest thing to sort of conquer or figure out? Because as we all know, microsurgery is in a very, very exacting surgeon-based, the surgeon determines the outcome. We always know that. That's the, research studies have shown that over and over again. It's the surgical experience. So what was it that got you to where you were now? Like, what lessons did you learn?
Well, so as you mentioned before, standing on the shoulders of giants, I visited a lot of surgeons over the years, and visiting Bob Allen, Lisa Wu from Penn, you pick up all these just little techniques that seem little at the time, but they're just monumental in giving you a safer and more efficient result. But I think that the concept that's allowed me to consistently get great results in the last few years is really the avoidance of fat necrosis. Because trying to get a certain volume out of your DIEP flaps, I think is a little narrow-minded. I think if you wind up with a smaller flap, but that's perfectly well vascularized, second stage procedures such as fat grafting or even putting a small implant behind the flap just gives beautiful results. With a soft breast that the patient feels like it's normal, no post-operative imaging result issues, which brings me to augmenting these patients after they've had a flap, which is becoming very common. Patients are seeing it on the internet and actually coming to me asking for a hybrid operation, meaning a deep flap with a delayed placement of a small implant behind it. So that's becoming very popular, which helps us really focus on making sure we only deliver well-vascularized tissue that we can augment with an implant or fat grafting later.
I think, Mike, that's why I was so impressed with your first case, because given the size of that patient, if there wasn't a great microsurgical breast reconstruction and it was just a standard breast reduction without a flap, you might be more likely to see fat necrosis in a patient like that. But it's true in many ways with some of these larger patients or these larger breasts, when you have such a well-vascularized flap, their final result just looks beautiful. And that does eliminate these complications, and it also helps the results so much.
Sure.
Now, Mike, I got a question for you. So, I do a fair amount of breast reconstruction, but it's mostly implant and expander based. I got to say that as I'm sure you'd agree, the biggest challenge, the most frustrating thing we deal with in plastic surgery is post-operative radiation. And it seems to me like the indications for radiation are expanding. Many times we're in a situation where patients may not, but going into the operation, we think they're going to be safe. They're not going to need post-operative radiation. And then, the indications for radiation are expanding. Those types of patients are getting radiated after surgery. And the only option I have many times is when I place an implant is to overexpand it and hope for the best, and hopefully the implant won't constrict down, and then subsequently put a smaller implant in at the time of the exchange. So, tell me a little bit about your experience with postoperative radiation. When you're doing you're doing a bilateral flap, you set it up for success. What do you do in the patients that are unknown radiation candidates?
I think one of the most helpful things to do is to actually make that breast a little bit larger. You can almost universally expect the breast to shrink somewhat. And I think by doing that, we don't run into a lot of problems with the breast being very small afterwards. And the reason why that's important is because before, when I was discussing about making a post-op deep breast larger, the problems I've had augmenting a post-operative deep flap is the radiated deep flap. And you would think that with a big chunk of healthy tissue, you don't have the implant-based problems relative to radiation anymore. That's not true. Even putting in a small little 200 cc implant behind a radiated flap in my career has had some issues. The vast majority have done fine, but the times that I've had issues with augmenting a deep flap were in the radiated patients. So I think it's important to make that flap larger so we're not looking at trying to make it larger after the radiation.
Right.
A quick technical question. Do you use couplers for any of your anastomoses, and how do you monitor your flaps post-op?
So I use couplers for all of my venous anastomoses. I borrowed a little tip from a paper from MD Anderson. If the venous anastomosis is less than 2 millimeters, especially in a radiated side, to hand sew the vein. So that's the only instance where I will hand sew a vein. But otherwise, 99.9% are coupled. The artery is done with the interrupted 9-0 nylon. A few of them I will run, but the vast majority are interrupted 9-0 nylons. Now, for monitoring, I use both an implantable Doppler probe and a Vioptics tissue oxygen saturation monitor. The reason why I use both is sometimes one is usually glitchy, and at 2 in the morning, if I have a Vioptic signal that's not picking up and get the call from the nurse, and I ask her to put the venous Doppler up to the phone and I hear a roaring vein, I can easily go back to sleep. If you have a problem with both and the flap looks a little different, then it's time to call the OR. You know for sure there's a problem, and they're having the patient in the OR by the time I get to the hospital.
How much?
So I like two methods of observation, and I can't reliably expect the nurse, maybe a new grad, to interpret the temperature, the color, the turgor of a flap, especially in a skin sparing with a tiny skin powder.
That always brings up the question in my mind for these microsurgeons is how much longer do you plan on, continuing with microsurgery? Because, that's not so easy on the lifestyle because, like you said, you never know when you have to go back. It's very arduous, the whole situation in terms of this, So what is your plans? Like, how long do you foresee yourself doing microsurgery for?
Well, I don't foresee stopping anytime soon. I've got to tell you that I love doing this more than anything. It is such a thrill to be able to help people, and the technical challenge and the mental challenge. It's all what just brings me immense professional satisfaction and personal gratification as well. It just feels good to be able to accomplish something like this. Fortunately, I hope I'm not jinxing myself, but we have very few early anastomotic vascular problems. That's just they're far and few between. We raised flaps with 2 or 3 perforators, a little slip of muscle in between if we have to, not relying on single perforator flaps unless it's massive perforator. We just have very few problems early on. But granted, I can't go too far. I can't, if I do one on Friday, even if I'm not on call for the weekend, I certainly can't go out of town. So you're right. It does hinder some aspects of my life, but, we plan around it and make sure that there's weeks when I won't have flaps where, we can get out of town for a while.
Well, luckily, with there being a global pandemic, there really is nowhere to go. So you might as well have a bunch of flaps.
That's right.
Mike, these are amazing results. And again, I just hope our viewers understand just how special these results are. And breast cancer is a horrible diagnosis, but there is clearly a silver lining for your patients if they can get these sort of aesthetic results and be treated successfully for their cancer.
That's great stuff, Mike. Great stuff.
Thank you so much for sharing it with us. And I think that's about our time for today. So we'll wrap it up. And again, if patients want to find you or find your team, what's the best way, particularly if they're not in Spartanburg, for them to find you, Mike?
Sure. My website is Orseck MD, ORSECK MD.com. Instagram is dr.orsek. So we have easy ways to contact the office. If you just want a little bit of information, just shoot us a line. We'll get right back to you.
Wonderful. Well, have a wonderful Sunday, gentlemen. And thanks so much, everyone, for watching. Take care.